Now, I'm very pleased to welcome Helen to speak to us. Helen is an intensive care nurse with 12 years of experience. Her professional interests revolve around the improvement of the quality of patient and family-centred care, which led to the development of the MICE project, which is measuring the intensive care experience. It's such a cute acronym. I think it's really cool. With the support and vision and guidance of a Senior Research Fellow, Associate Professor Nicholas Ralph, and the SVHA, via funding through the Inspired to Care grant scheme, the MICE project has successfully developed a reliable and valid survey instrument used to inform a range of quality improvement opportunities. And that is what has led Helen to be invited in to speak to us today. So,
Thank
over
you.
to you.
Thank you. It's such an honour to be here, and I'm very excited to be presenting this. The MICE project, Measuring the Intensive Care Experience, is a research initiative of the Intensive Care Unit at St Vincent's Private Hospital, Toowoomba, and in collaboration with the University of Southern Queensland and Holy Spirit Northside Private Hospital, Brisbane. Our objective was to develop, pilot and validate items within patient and family experience surveys developed for the Australian intensive care environment. I'd firstly like to acknowledge the project team that I've had the privilege of working with, including Associate Professor Nicholas Ralph, Dr. Sharon Rees, Juliet Stevens, Elaine Bartlett, Amanda Porter, Dr. Meher Chintamanidi, and Dr. Alan Rouse. And I would also like to acknowledge that funding for this project was received through the SVHA Inspired to Care grant scheme. This may be a normal day at work for you, but it's a big day in my life. As clinicians, do we always remember and heed this advice? From a personal experience, I had 2 friends who were patients in our intensive care. I was shocked to hear that they didn't have the best experience, particularly in terms of psychological and emotional well-being. This led me to look into how our ICU performs in terms of patient experience, and I found that our hospital satisfaction survey, like many others, does not isolate the intensive care area. So in a high acuity technical area, how do we measure this experience? It was from this that our project, Measuring the Intensive Care Experience, evolved. Measurement of quality outcomes in the ICU is usually reported by the length of the admission and the survival rates. However, the psychosocial experience of the patient is often neglected. Literature suggests that an intensive care admission has significant implications for post-discharge health status, particularly psychological well-being. Specifically, many patients report one or more of anxiety, depression, post-traumatic stress post an ICU admission, which is closely related to their experience in ICU. Despite this, there is a lack of research and data on reliably measuring the patient experience in ICU. We proposed that a validated patient experience survey would establish a baseline instrument for comprehensive quality improvement, both in terms of clinical practice and patient care. In 2017, we developed the first validated multi-perspective survey instrument for comprehensively measuring the quality of patient experience in Australian ICUs. The initial phase of this project was survey development. The research team conducted a systematic literature search to generate different items. From our review of the literature, we noted several other ICU surveys and observed their strengths, limitations, and measurement focuses. The MICE survey was designed to include both medical and nursing care evaluation. 2 surveys were produced, one for the patient and a matching survey for the family. This enabled us to view the patient experience both from the patient and the family perspective. We used the Australian Commission on Quality and Safety in Healthcare Patient Experience Indicators, along with findings from the literature, to derive survey items across 4 specific survey domains. The 4 factors included about your treatment in ICU, about the care you receive from your ICU doctors, about the care you receive from your ICU nurses, and about your ICU stay in general, as well as a demographics and general comment section. Ethical clearance and site approval was received to carry out the study at St Vincent's Private Hospital, Toowoomba, and Holy Spirit Northside Private Hospital, Brisbane. It was decided to pilot the study at both sites to test its effectiveness at units with differing levels of acuity. The ICU at St Vincent's Toowoomba is a 6-bed, level 2 ICU, catering for a range of patients from general multi-system care to high dependency, post-operative and CCU patients. Holy Spirit Northside, Brisbane ICU is a 15-bed level 3 ICU with approximately 40% of their admissions comprising of post-op open heart surgery patients and otherwise general ICU admissions. We collected 272 surveys in total. 158 of those were patient surveys and 114 family surveys across 2017 and 2018 through both sites. The surveys were paper-based and were distributed both to the patient and their family within 24 hours of transfer from ICU to the ward. Participants were visited and briefed about the research and provided with an information sheet. This post-transfer visit also allowed for a worthwhile interaction to touch base with our patients following their transfer to the ward. After the completion, the surveys were then placed in a sealed envelope for return to ICU. The data was then analysed by a statistician, and it was identified that the MICE survey recorded the highest levels of internal consistency of any ICU survey reported in the literature to date. Moreover, the survey maps with Australian Commission on Safety and Quality in Healthcare indicators, meaning that survey findings can produce instant feedback for hospital accreditation. In summary, the MICE survey has a wider focus than other comparable surveys, the highest level of internal consistency among comparable surveys, and survey findings can produce instant feedback for hospital accreditation. Overall, the responses from the survey indicate patients were satisfied with their experience. Interestingly, the least number of strongly agree responses were reported for the question whether staff members involved the patients or their family members in the decision-making process. Other replies, such as felt prepared to move to the ward and staff supported me to get adequate sleep, were associated with lower levels of agreement. Pearson's correlation coefficients were calculated between the patient's versus family members' responses based on several characteristics such as age range, length of stay, gender, and planned or unplanned admissions. The significant correlations at the 95% confidence were, the older the patients were, the less they were likely to agree that they had a positive experience in the ICU and that staff supported them to reduce their anxiety. Noticeably, a longer stay was significantly correlated with positive experience in the ICU. Patients also expressed favourable views towards pain assessment and whether the nursing staff attentively listened to the patient's problems. Female patients strongly agreed that doctors maintained their privacy and had confidence in the nursing staff treating them, and were also significantly likely to agree that staff had a good attitude towards visitors. Table 3 illustrates findings from the multivariate general linear model test. The results indicate that different characteristics of patients significantly influence their ICU experience. For example, length of stay is significantly related to effective pain management of the patients. Male respondents showed more confidence in the doctors and nursing members for their ability to provide medical treatments. Patients with higher education level report a significantly higher positive ICU experience. They showed more confidence in the doctor's ability to treat, care, and understand the condition of the patients. And finally, the ICU experience of patients who had a planned admission was significantly better compared to those who had an unplanned admission. Those with planned admissions showed more confidence in the ability of the doctors and the nursing staff to treat the patients. Locally, several key care priorities can be identified from the survey findings. Patients have indicated that they expect an improved education about their experience during ICU, support for sleep, and medical involvement of family in their care. Based on these findings, we plan to review the literature to identify models for patient and family education in the ICU, identify interventions for improving sleep in ICU patients, and identify models for improving whole of ICU communication. The survey will be crucial in practice development as it will provide a before and after measurement point for evaluating whether changes have been effective. Future directions of this project include implementing improvements to address several care priorities identified in this survey, establishing an ICU patient experience registry at St Vincent's Private Hospital, Toowoomba, to track outcomes and unit performance over time, and leverage preliminary findings to scale up the project across St Vincent's Health Australia private and public hospitals. Whilst these scores are important, the project is more than just the response on the surveys. This is only part of the story. The challenge is now to go beyond the data and put these results into practice to truly make a change in our patients' lives.
Thanks, Helen. Have we got any questions from the floor? Yep.
Good afternoon. Thank you. This looks very beneficial and very useful. I'm just wondering if other professions service your ICU. I note that it's very much medical and nursing, and such a survey would be so valuable if it contained perhaps the entire cohort of staff that would be servicing your ICU. Have you looked into expanding perhaps allied health feedback?
Actually, that's such a great question. Thanks for asking that. We hadn't actually looked at including allied health previously, but thought of that actually, so I'm sorry to the allied health professionals in the room. But I think that would be a very worthwhile, where to next really, to include. So thank you.
It's not so much a question, but a comment. The whole movement towards patient-reported experience measures, or PREMs, came after PROMs, and it's really been driven by the health economists, really. So I just want to congratulate you and your team for taking the effort from the clinician side. So well done. I look forward to the future with you guys, seeing what you guys do with it.
Thank you.
So I thank you to Helen and all our speakers and everyone who contributed with questions. Thank you for making this session your session of choice before lunch. We look forward to seeing you throughout the throughout the conference. I'm so used to trials. What's that about? Anyway, but please encourage you to go up and speak to the speakers if you have any further questions. Thank you.